No matter the health issues, all pre-existing conditions should be covered.
You don't have any insurance, so I can't do it.
I waited all morning to see the doctor, and then he did not listen to me.
When I go to the doctor, I want to be heard. I don't want to feel like I'm on a conveyor belt.
Doctors should talk to us.
Healthcare should be a right, not a privilege.
Some things you can get if you got great insurance, if your job offers that and you can afford it. Some things you can't.
We deserve to be treated equally. Why should we have to die before our time?
There are many challenges today in the delivery of healthcare. These challenges affect not only patients, but providers as well.
I'm not able to stand a long period of time. I can't do that much walking. I have to, stop, rest, sit down. And it's the constant pain. Even when I'm sleep, it's throbbing. That's just what I have to deal with every day until I'm able to get the knee replacement if they're gonna give it to me.
I see people in pain, and it breaks my heart that I can't, with my medical knowledge and keeping the patient safe, I cannot do what I am trained to do, which is to help take care of your pain.
If my knees are so bad that I literally cannot walk to the corner or I can't do anything without my knees hurting and I need a knee replacement, technically a knee replacement is elective surgery. If there's not an equal distribution of providers to offer that service, then by the time I get to that service, I might be worse off.
If I'm sitting here, I could take this off and I would be fine. It's when I walk from here to the car to the store, the level goes down with the activity. Because I know most of what is wrong with me I'm doing to myself by not eating right, not exercising. If I did those things right, my health would probably get better.
My health issues are I have diabetes, hypertension. I would say probably the biggest challenge I face is making exercise, because I know that exercise would help improve all of those things, making exercise a priority with just the busyness of life in the day-to-day. Some people enjoy exercising, so therefore it's easy. It's not something that I enjoy doing, but it's something that I know I need to do and I have to do.
If you understand the consequences prior, then it makes it easier to make better decisions. In the setting of somebody who's morbidly obese and has advanced osteoarthritis, had many years earlier they made choices to not exercise, to eat more proportionally, they may not have developed a morbid obesity.
Most African American women or families live under the poverty line. If you don't have money, you're gonna buy what's in your neighborhood. What's in your neighborhood? Stuff that's in a can, stuff that's processed. It's nothing fresh. And a mother who's gonna go and feed her kids, she's gonna make a decision, what I call, mama gonna work it out, or am I gonna get some salad and we're gonna have some water, or I'm gonna make some fresh juice.
My African American patients, and especially my African American women, a lot of times they're the single parent in a household, so there's financial burdens. Sometimes there's a decision whether we're gonna pay the rent that day, buy groceries, or buy blood pressure medicines, because we have kids to feed, we have rent to pay.
I had went to Mercy to see an orthopedic doctor about my leg after I had the surgery. And they told me I could not see. Had 4 different appointments with 4 different doctors. I never seen the doctors, but when I got to the office, they said, we don't take this kind of insurance.
Some patients who can, based on their insurance, they have access to, more things. For instance, if they have a Blue Cross Blue Shield PPO, that's within a group plan, then that's a better type of insurance. And so they have better access to some of the things that are required to care for them. As I'm seeing patients who drive 2 hours, 3 hours to see me because there are no other doctors who will take their insurance.
I think one thing is, I think we have to do a better job of educating patients and the public of what different forms of insurance mean. Because when people are making their decisions, there may be patients who are in position, let's say, to have better insurance plans that don't limit them, and may make a decision to have an insurance plan that is more limiting, not recognizing the consequences at the time that they're making that decision.
I can't afford it because the cost is between $25 to $50. That's too much for me with what I make.
High copays. For the great deal of the population, copays over $25 or $30 a visit make going to outpatient physical therapy prohibitive.
And it's also the communication, because sometimes I've talked to a lot of patients, believe me, and they tell me it's the lack of communication with the doctor. The doctor's sister goes on his computer, asks you 20 million questions, and when you want to ask him a question, he goes, hold on, let me finish doing this.
Computers catch many things, and they're good for many things, but when 90% of your appointment they're inputting in the computer, then you lose that face time, because you don't have very much time, with the doctor. So you lose a lot of that if it's spent in the computer.
I hear that from a lot of Latino patients. They don't feel when they go to a provider that the provider listens to them, that they rush them through a visit without listening to the concerns that they have.
My mother-in-law's been having this trouble. Her doctor, she goes and sees her doctor and she has questions and stuff, and her doctor's just blows her off. My mother-in-law says she feels like she's on a conveyor belt, in and out.
A lot of patients have the experience that we as providers don't really listen. We're not taking on their cases individually. They're just being run through a conveyor belt. They're questioning whether the care is valid and effective and personalized.
I went to the hospital and they said, oh, you had an appointment, but the doctor's no longer here. I said, okay, so where does that leave me? She goes, you're gonna have to come back when we get another doctor and we will call you. But that was the hospital that the insurance told me I had to go see. It took almost now a year, and I finally saw the doctor yesterday. So now, from now to when I have to get the surgery, I have to do co-payments because I don't know if my insurance is gonna cover it or not, but I'm gonna have to do it in order for me to get surgery.
They're going to cease the states paying the safety net hospitals money for taking care of the indigent and not getting any and not getting reimbursed, not getting any money. So for this hospital, for instance, that would be a $20 million loss. And I don't know too many institutions who can sustain a $20 million loss. The public needs to know what we're going up against.
I need hand surgery. I've had hand surgery in the past. My joints, because the osteoarthritis has really degenerated my bones, so I'm having a lot of issues with my hands. But I haven't planned my surgery because of that, because at this moment, the insurance does not cover my hand surgeries. And I'm on a standstill on that.
As a physician, you're employed by a larger group or a hospital. You're basically at the mercy of the hospital as to what they take. And all that's based on reimbursement. Even though it would be wonderful for everyone to have access to care, when you walk through the door, we can do whatever you need. We still are in the healthcare business, a healthcare market. So we have to keep the lights on some kind of way, and that comes back to reimbursement. And that's how the hospitals decide which plans they take. And that can definitely limit access if your plan doesn't reimburse as well.
The transition to value-based payment models will create some challenges in healthcare delivery.
Well, when she was telling me that if I lose some kind of weight, my pain in the knee gonna relieve a little bit. I have been so hard-headed, and I don't do exercise. I don't listen to her, and she say to look for another doctor.
The most important thing for me is to get an excellent outcome. I believe I can get an excellent outcome with someone that might be obese, that may have diabetes, but I need that partnership. I need that patient to work with me. So if you come into my clinic and your blood pressure is out of control and your blood sugars are out of control,
and we work together and we improve those, then yeah, we may delay your surgery, but we will take care of you. We will do that surgery. The challenge though is if 3 months later nothing's changed, then what can I do? It's not necessarily me turning you away. It's me saying, hey, I need you to partner with me, and are you really ready to partner with me in your health?
In what I believe was a well-intentioned effort to improve quality of health care in this country, directing those quality efforts at both doctors and surgeons as well as hospitals, payment systems have evolved to say, we're going to penalize you, the hospital, if you have, for example, a higher than expected number of readmissions.
At some point, you can't keep spending money. We do have to ration, and nobody likes to use that term, but really that's what value-based care is. We've got a set amount of money. How can we use those resources to best improve the health of our nation?
So they then begin to make decisions about who are the ideal patients for purposes of getting paid, and getting paid at a rate that they think is fair, and they begin to cherry pick and market themselves, fight for those patients so that they can get the best insurance, and to avoid the patients who are going to come in uninsured or with insurance that pay with a low rate.
Once again, they're much more likely to take on patients who represent a lower risk or less likely to have a longer stay in the hospital than what the payment model may have assumed.
That is just really mind-boggling that they would think that would be good care. And because you don't know. You don't know what's going to happen. When you have surgery, you don't know what you're going to see until they cut the body open. What they think might be simple might be difficult. And so now, because you think this person might be difficult, we're not going to operate on them because it might cost us money. That's inhumane.
They get paid the one time, and if there's any readmissions, the hospital does not get paid at all. So that creates some challenges, particularly if you have major complications that are very, very expensive to care for. And then where are those funds coming from?
I firmly believe hospitals are not the boogeyman here. Hospitals, in general, are dedicated to providing care to their communities. I think the vast majority of hospitals are not for profit, and they are embedded in their communities, and they recognize that they have a moral responsibility to providing care. At the same time, hospitals still have to make a margin. No money, no mission.
Bias is a reality, and it does create disparities in the delivery of health care.
I think race concordance is important because I think you may have biases when you first see a patient. And you may look at a patient, and in the first couple minutes of your interaction, the way the patient speaks to you and you speak to them may create a tension based upon what you previously have thought about different individuals, and you may already make a judgment about that patient.
Some doctors really don't want to deal with overweight people. I really believe that. I've seen that happen over the years.
There is still a lot of conscious racism, and the conscious racism has been unleashed in a way that we've never seen it before in recent times, so that if one assumes, for example, that healthcare providers are normal, ordinary Americans, and you have 30 million people who have consciously racist views, you can assume that if a certain portion of those are going to be healthcare providers. So when you do studies of areas, urban areas, now you find out they're very racially segregated. Now what that means is, if I live in a racially segregated area, and we then add on to it the conscious bias and unconscious bias, and we then add on to it lower economic resources available, just by being in that community, the structure is such that I'm going to be going to a doctor or going to a hospital more than likely that is going to have less resources than the hospitals that exist in a more affluent area.
But when it goes to those levels and then it becomes a finance issue, then we have the situation is not equitable. It's not equitable.
You need to focus on preventive care to change lives.
My commitment is patient empowerment through patient education.
Does the healthcare system provide for the patient an inkling of control of their destiny?
Everyone in this country deserves equal and equitable health care.
We need to create a healthcare system where every human being in our community is treated with respect.
For a healthier community, it starts with us.
I challenge you to take charge of your health.
We need opportunities to engage patients in the healthcare system.
Leadership in healthcare is leveraging your resources to provide equitable care for all.
Patients have a right to be a part of their healthcare plan.
We have a responsibility to provide equitable care for all.
Access to health care is something every American has a right to expect.
We need radical change to ensure healthcare equality in our country.
We're sisters and brothers. We're all connected. We should be helping each other.